Should we start? Okay. Well, welcome. I'm Shirley Fenton, manager of the Infonet Project and one of your hosts today. And a very special welcome to those of you, we think, that are viewing this presentation in Sault Ste. Marie. This is our first test, I guess, at doing these presentations virtually. So I hope it's successful. And if it's not, please bear with us. We're going to make every effort to make this a good presentation virtually and for those of you here. This seminar series is a joint effort between the Infonet Project and the Waterloo Institute for Health Informatics Research. We thank you for joining us today for the second seminar in the series, Emerging Solutions, Health Informatics Tools for the Future. The idea embodied in this theme, for those of you that weren't for the first session, with us for the first session, is to have presentations on technologies, concepts, methods, or processes that are new, emerging, disruptive, innovative, or ingenious, and that have potential for positively impacting health or the health system. I understand that the last month's seminar on My Care Source portal was very successful, and that this will be a very exciting series. We are very pleased to have our colleague, Dr. Ed Brown, with us today. He's the Executive Director for the North Network Telemedicine Program, one of the largest in Canada. I'm not going to say anything about Ed or the program or his talk. I'm going to leave that to my colleague, Dominic Covey. So Dominic, who is the Director for the Waterloo Institute for Health Informatics Research at the University of Waterloo, will you please introduce our speaker? So quickly change the microphone to Dominic here.
Are you a union?
If you want to take that, just take that and you can hold it.
Well, welcome to you all, both here and outside. You can read the formal blurb on Ed. I'll give you a few words from it and then talk very briefly about what I know about Ed, which I think will go far beyond what he said here. He's an emergency physician. He's the founder and executive director of the North Network Telemedicine Program, which is an amazing program. I believe it's not only the largest program in Canada, but the most complete program in Canada. And we were talking with Ed earlier, and from what I know, it actually went through very tough times. It was a very difficult process. So we have here not just a person who's founded something, but that's actually dragged it, screaming and kicking through history that is quite challenging. And I don't know to what extent he'll share that with us, but I think it's important to know that this was a very difficult and challenging effort to accomplish what Ed has accomplished. He's worked as a consultant for the Ontario government and for Smart Systems for Health Agency. What's interesting, and we actually created a new criterion today of who can speak at our seminar series. We're allowing no further UW alumni or alumnae. We discovered that Ed is also an alumnus at the University of Waterloo, where he was in applied mathematics and system design. So yet another person comes back to us. We're utterly amazed by the number of people in the area like health informatics that have trained here at the University of Waterloo. It's been really exciting. He's also won an award. I was not aware of this. Is the recipient of the 2003 Canary Highway Award for National Leadership in the Development of Canada's Information Highway. I've known about Ed for a very, very long time. His work was known. We did work with Telemedicine Canada years ago and heard about the startup of his work. The challenge of doing this in terms of anything from the political, the economic, getting content, getting people to participate, getting the connections, I think if you look at it, is quite unbelievable. And I think that what he's accomplished will be one of the high water marks in Canada. So I'm very pleased to have you here today, Ed. And I'll look forward to your presentation on the North Network and the future of telemedicine.
But thanks for the nice introduction. This is the first time I've ever had two microphones. It could only happen here at the high-tech University of Waterloo. And for those of you out in virtual streaming land, there's actually a chip in my brain and that they put in just before this session. That's how you're hearing me. But it is true, I was a University of Waterloo graduate, so I'm an example of what can happen to you after you leave University of Waterloo. In my case, that means losing your hair. But some of you I see are already working on that, and that's a good thing. So what I'd like to do actually is tell you what I'm going to do today. I'm going to tell you about our network, the North Telemedicine Network, really go through the technology and services that we provide and some of the special projects, and at the end talk about our future plans. This is advertised as the future of telemedicine, and I think what you'll see here is not the land on the moon, build a new civilization type of future. I'm talking 1 to 3 years. These are things that are going to happen over the next 1 to 3 years in Ontario. So we're going to do real stuff here. Basically, I need to tell you what we do primarily, which is two-way video conferencing to support health professional consultations with patients over the distance. Here you see, in this example, a cardiologist. At the other end is a patient with a family physician. This is actually not exactly accurate because usually there's a nurse. Usually a nurse is with the patient, and they're actually doing medical care over a distance. They can talk to each other. They can see each other. The physician can use a digital stethoscope to listen to heart sounds and breath sounds. There's handheld patient exam cameras to look at wounds and rashes. And of course, we can send digital images as well, like x-rays and ultrasound, if the facilities are there. This is real medical care. This is happening every day in Ontario. In fact, we're now doing over 1,000 cases per month in over 70 different specialties. And we'll show you more about this in a second. The confusing thing, who's from Ontario here? Everybody here? You ever heard of Telehealth Ontario? Telehealth Ontario is the nurse call center, right? So you have a magnet on your fridge, and if you get sick, you call them with your cold, and they tell you, you have a runny nose, go to the Emerge right away. That's Telehealth Ontario. And people confuse that because we do telehealth too. This is the real telehealth. In fact, I think that my mother thinks I run a nurse call center. She's not quite sure. It's that confusing. But just so you're absolutely sure, this is what we do. We do medical care. The other thing we do is education. So we use that same set of technology, multi-point video conferencing in our network, anywhere up to 75 separate locations, which all link together for real-time video conferencing. Usually some guy like me with a set of PowerPoint slides or a patient case presentation or whatever that happens to be. And this, again, is a very popular service in Ontario. This next slide actually shows you where we are. All of those red spots that you see across the province are not measles in Ontario. Those are communities that have one or more telemedicine site. Actually, this is a bit old now. There's actually even more of those measles right now. By the way, these were all blue before the last election. Right? We're very strategic. But if you look way up here, some of them have exactly one studio. Like there's a nursing station in Fort Severn, Health Canada nursing station. There's one telemedicine studio there. If you come all the way down here to Toronto, there's actually 12 different sites, over 30 different telemedicine studios scattered around the city of Toronto, and everything else is kind of somewhere in between that. Most of these are actually community hospitals. So in most community, it's the hospital in town that hosts the telemedicine. But there's a whole bunch of nursing stations. Our partner in the far north is Keewatin-Okimakanik Tribal Council, and they're supporting telemedicine studios across the remote north. There's actually no roads up there. These are all fly-in communities. So either you see the doctor through the telemedicine technology or you take a plane somewhere. Those are your two options. There's educational facilities that are online for training residents. We even have doctors' homes, doctors' offices hooked up so they can take call. There's 4 psychiatric hospitals, 3 cancer centers, air ambulance facilities, and a whole bunch of other type of sites that are online. This is where our staff is. We have about between 50 and 60 staff right now. About half are here in Toronto, but in each region there's staff that support that region. So there's a big contingent in Timmins, that's our clinical center, Sudbury, Thunder Bay, Barrie, Ontario, somebody in Ottawa, and our First Nation partner is up in Sioux Lookout in Red Lake supporting all of the First Nation communities in the far north. By the way, just stop me if you have any questions. Do we have online participants, by the way, just out of curiosity? Is there anything I have to do to entertain them differently? No? They're watching everything? Okay. Great. So, why are we bothering to do all this stuff? There's a huge shortage of health professionals across the province, and this is today dramatically improving access to care. Also, health professional recruitment and retention. We think that this may be a factor in promoting both recruitment and retention. Actually, we had a student recently who did a study for us to try to find out if, in fact, this was an issue in recruitment of new medical students looking for a place to practice. And he said that actually in Ontario, this is not a factor. But actually, it's a reverse factor. When a student comes out of school, they want to know that there is telehealth there, and if there isn't, they're much less interested in the community. So they're starting to assume that this is going to be something that they're going to have just as part of their everyday practice. And of course, the other piece is reducing the cost, reducing the travel of patients, physicians, and other health professionals. Anybody here in the technology field? Yeah, most of you? Okay. So I should probably tell you about the network we use. When you looked at that last map, what you saw there was really a giant IP network. So all of our sites are connected through a managed private IP network. It's actually a set of internetworked networks. So the biggest provider is Ontario government's infrastructure called the Smart Systems for Health Network. They link up all the hospitals. Our First Nation partner in the north has one of the most advanced remote networks in the world that covers that whole Sulaka zone region with digital wireless and satellite, and that's internetworked into the larger network. We also use Canada's national broadband network, CANet 4, and the Orion network to bring in sites. We have facilities in Winnipeg Health Science Centre that do that. And we also use plain old DSL circuits and other local technologies to get into people's offices and homes. All of these sites are brought in securely through VPN technology, standardized technology that ensures that there is security and quality of service. So, what do we do? Well, we've been doing this for, we started in 1998, actually. We started with 4 sites in northeastern Ontario. It wasn't quite as hard as Dominic said. We had fun for those 7 years. But we've learned a lot over the years, and these are really the success factors. So if you want to go home and start a telemedicine network, I would write down some of these points because these will help you get the thing started. I think probably the number one thing is right here, local staffing, local champions, and regional leadership. What you don't want to do is be a guy with a tie from Toronto, flying up to small communities like Cochrane or Sturgeon Falls, and trying to tell them how to run their healthcare system. Because you won't last very long. They'll find you a train or a bus or a plane out of town pretty quickly. So you don't want to do that. What you want to do is make this the local community's program. So what we do is we have a medical director, a telehealth coordinator in every community, and it's really their program. They decide what their community needs, they decide what they want, and then us, the folks who run this program, provide the leadership to try to get them the stuff they need and to bring people together across a region. We actually have meetings every couple of weeks with all the people in a sub-region to talk about what works, what doesn't work, complain about our service, or tell us what went great, and build new initiatives and keep this alive and active. You have to pay doctors. I don't know if any of you see a doctor, but they usually like to get paid for what they do. This is not a benefit of our health insurance network right now. So we actually have to pay the doctors out of our program budget. And we manage their referral and scheduling requests. So if you go to your doctor right now and you got to see a dermatologist, on a piece of paper they'll write dermatology, and he or she will hand it to their assistant and the appointment will happen. Well, with telehealth, you got to book several studios, equipment, nurses, remote specialists, doctors. If we asked the family physician's office or the specialist's office to organize that, there would never be a telehealth consultation in Ontario. So we've set up what we call our Office of Magic. It's a formal call center located in Timmins, Ontario. We've automated it. We've gone through several revisions of the software package to automate that, and they magically make this happen. So a doctor or other health professional will fax in their request, and 2 weeks later, the thing will just kind of happen. I won't go through all of these, but training is really important. Whenever you do IT projects, you got to spend a lot of time, energy, effort on making sure that you've deployed the change management strategies so that people will use the stuff that you're building. And we've set up formal training programs for particularly telehealth coordinators or nurses called the ABCs of telehealth. We train people, we remind them, we have reminder training sessions, we have materials up on the website for just-in-time learning. The technology is tricky. IP video conferencing, when we started 2 years ago, we were really one of the first to do it at a broad scale. It's become more popular now around the world, but the technology still requires a great deal of expertise to make sure that it's working all the time. And so we do that for our members. We wouldn't ask a small center to be able to do that. If you travel around rural Ontario, most of the IT professionals in the small hospitals also have jobs as the janitor or whatever other, so they're not highly certified IT professionals. And finally, our First Nation partner adapts what we do for the First Nation community. So they take our stuff and make it better and more relevant to their communities. So this is, you've probably seen this curve a lot of times in relation to technology. I usually think of the fax machine where, it worked pretty good for many years, but nobody had them. And then one day you just sort of had to have one and everybody went out and bought one. So we're kind of in this phase here where we're getting kind of popular. We thought we were doing great in '98, by the way, because all you math people know, if you blow up this little square here in the bottom, it looks like you're really going sky high as well. But we found that just over the past couple of years, the uptake of this technology is really taking off. We're now up over 1,000 patient consultations a month, and we don't know where the top of that is. This fellow with the red tie is the Ontario's Minister of Health. And he came out to our office to help us celebrate our 10,000th patient consultation, which was in February of this year. Actually, we're up over 16,000 now. But this just gives us an example of a patient and their story. So this was our 10,000th patient, a cute little guy named Callum, who is 3 years old at the time. And he lived in Marathon, Ontario. Marathon's kind of halfway between Sault Ste. Marie and Thunder Bay, a bit closer to Thunder Bay, but it's still a 4-hour drive from Marathon to Thunder Bay. And he got pneumonia. He was admitted to hospital. Usually in his situation, that would have been an ambulance drive to Thunder Bay to see the nearest pediatrician. Instead, the pediatrician saw him using the technology, looked at his x-rays using the technology, and this child was able to stay in the community. Obviously, he got better. His parents were very happy. They didn't get stuck in a snowbank in January or hit a moose, which can happen on that road as well. So we have 16 or 17,000 of these stories now to tell you. This is the typical sort of activity that we do. This is just an average quarter. This quarter, psychiatry was our most popular specialty, but also, I'm sorry if you can't read that, paediatrics, dermatology, general surgery, pain management, Parkinson's disease, oncology, neurosurgery, cardiology, so really a broad gamut of activity. Some of the stuff that surprised us was that a lot of surgeons are using this. Now, they're not actually doing the surgery over a distance, although if there is a volunteer in the audience that wants to be the first, right there, sign him up. You can be first. I'm not going to be first. But the surgeons are finding it tremendously useful for their pre-op assessment, so the patient doesn't have to make that first trip where the decision around surgery is made. And the follow-ups, this is fabulous for follow-ups because people would travel for a whole day for really a 10-minute appointment where the surgeon said, yep, everything looks great. So this way they're able to just stay at home and do this quickly. And some people have made this a core part of their practice. There's one neurosurgeon in northeastern Ontario, and every 2 weeks she holds a clinic and sees all her post-op patients across that region of the province. I focus a lot on the doctor stuff, by the way, but there's a lot more happening than just physician work. There's a lot of speech therapy stuff and OT and PT, and actually a lot of nurses are providing advice to very tiny communities that don't even have a nurse, which is quite interesting. Just another example, here's a guy, a neurologist who works in Markham, Ontario. He's a Parkinson's disease specialist. Parkinson's disease is a movement disorder, and people move very slowly. Unfortunately, every 4 to 6 months, they have to come to his office from all over the province to get their medication adjustment to keep them moving. Now, he's seeing them remotely. He started out in his hospital, Markham Stouffville. Now he's actually put the technology right in his office, and he's seeing patients virtually every day across a distance, saving them a huge amount of travel. By the way, that was his 100th patient who got a chocolate bar and a mug. And this is another, just one last example, dermatologist at Sunnybrook. This is our oldest telephysician, because he's been doing this every Friday morning since 1998 from 9 to 12. He sits in this room seeing patients across northeastern Ontario. That was his 500th patient who got a T-shirt. That's his favorite toy. That's a handheld patient exam camera. Great for looking at rashes and wounds. It's dead simple to use. Looks like a Fisher-Price toy, but it costs about $5,000. So we ask people to try not to drop it if they can. This is the sort of thing you learn when you've been doing this for a while. When we started out with that particular dermatologist, the nurses would hold the camera and they'd try to get a close-up of the rash, get to the right spot. And so he was at the other end, and he was starting to look green. It was like the ship is moving. And he had to close his eyes and wait till he did it. So we learned from that, and we sent tripods out to all of our sites, and now the camera is stable and mounted, and he's much better now. This is a cardiologist in Sudbury, and this is his favorite toy, a digital stethoscope. We also use an endoscopic light source, which you can attach all kinds of stuff onto this. You can put, I guess mostly ENT is what folks use it for, but we have one physician who's an endoscopist in a small town in northwestern Ontario. Actually, this is an interesting story, because he's a family physician who somewhere along the way learned how to do gastrointestinal endoscopy. He can either go down through your mouth and look in your stomach, or up the other side and look around in there. And unfortunately, in northern Ontario, there are much higher cancer rates than there are in southern Ontario for a bunch of reasons. And he actually, unfortunately, finds a lot of cancers. But what typically would happen to him is he'd find a cancer, he'd send the patient down to see the big city surgeon in Toronto or Hamilton, and they would have to, actually, they didn't believe him, because he was just a family doctor from a small town in the north. And they wouldn't believe him, so they would actually do the same endoscopy again to make sure that the patient had cancer before they did the surgery. So he set up a system where he takes one of these things into his room and actually now records the images from that endoscopy and stores them in a PACS archive. And now when the patient gets sent down, the specialist can just look at the images that are down there. The patient doesn't have to have the same procedure twice, and of course our healthcare system saves a little money. So really an excellent application of the technology. That's the sort of image you can get. So this is where we are right now. In terms of the people using this for clinical purposes, we've got about 2,000 physicians who are active. There's about 680 medical specialists who are seeing patients over the network. About 200 other allied health professionals using it for clinical purposes. In addition, there's probably about 3,000 users a month who are active in educational events beyond the clinical users. Education, there's about 150 multi-point events every month. One of the exciting uses is actually the medical schools training their residents who are practicing in rural areas. But there's also all sorts of meetings that happen on here every single day, and if you look at the list, there's all kinds of things you can learn if you want to. We've done a number of exciting, we call them just-in-time educational sessions. We did one during SARS. Actually, during SARS, SARS-2 happened at North York General Hospital. In the middle of that, we were asked to wire up North York so they could do video conferencing with other centers. It was kind of exciting. It was, our guys kind of showed up in the parking lot. Their guys came out in masks and gowns, and they kind of did a trade of the technology. It was like a drug deal. And that got them set up. And then we had about 50 sites, all multi-point video conferencing and doing live webcasting to about 420 physicians, just on, what do we do? We're in the middle of SARS, which was very well received. We did the same thing, not this past summer, but the summer before for West Nile virus, because nobody knew what to do with West Nile, and it was just starting to get popular in Ontario. Again, close to 50 hospitals hooked up. So this is really quite a valuable public health tool. Once you get the sort of wide distribution of sites that we have, you can reach a lot of health providers with this technology. We operate under a membership model. Our core funding now comes from Ontario's Ministry of Health and Long-Term Care. That started last year. We've really received funding from over 100 organizations over the past 7 years. Our biggest boost came from Health Canada just in 2001. But all of our sites are also members that work with us, and that includes now more than 75 hospitals. Keewatin Okimakanek Tribal Council is our partner. Cancer centers, psychiatric hospitals, professional associations, that includes the Ontario Hospital Association, Ontario Medical Association, Registered Nurses Association. And now we're heading out into the community, long-term care facilities, VONs, family physician clinics, nurse practitioner offices, and a whole bunch of others. This was our launch with our partner in Red Lake, actually. And so that membership model, what that does, there's a small fee associated with being a member. But what it does is also have everybody sign up a contract with us that says, I'm going to follow the standard that everybody else is following. I'm going to follow the technical standard. I'm going to schedule in the same way. I'm going to respect your privacy and your security at your end. I'm going to assign the right people to this job so that they can be trained appropriately, i.e. a telehealth coordinator. So really, this membership is all about all of the sites really agreeing to a basic way of operation that enables you to go anywhere to anywhere. So you know that all the other sites across the network are doing what you're doing and are going to respect your security and privacy and other pieces of the puzzle. And that's why it works. It's really a big collaborative effort. It also allows us to take the core funding that we have and leverage that so that, if you're a cancer program, for example, you might pay us $5,000 a year to access, 80 sites that you want to go to. If you tried to build it yourself, you'd have to spend the $20 million that we just spent. So the business case is, do you want to spend $5,000 or $20 million? So that's a tough decision for some academic economists, but for most people it's pretty straightforward, and that's why this works. So we aggregate people to use the same pathway, right? Just for the legal folks out there, CPSO is the College of Physicians and Surgeons of Ontario. They're the ones who can taketh away your license if you're a physician. And the issue here is that you get licensed in every province. So if you're a doctor practicing in Ontario and you go over to Nova Scotia and you see a patient, you're practicing without a license, right? So telehealth lets you practice anywhere. So if I'm a doctor in Toronto and I see a patient in Halifax, am I doing that in Ontario or in Halifax? Should I be going to jail because I'm practicing in another province? So that is totally unresolved. People go ahead and do stuff, but we need to have some policy in the country to help us resolve that issue. The only resolution we've had is there's a lot of activity between Winnipeg and Northwestern Ontario. We have had those two colleges agree that for the purposes of this project, we are fine with doing that over the border. I have a little letter that I keep locked in a vault that says that. But we have to resolve these larger issues to move forward. CMPA, now that's the group that when the patients try to sue us doctors, the CMPA protects us. They provide the lawyers, guns and money to protect physicians. And they have stated that physicians will be insured for their telehealth services within Canada. So we're comfortable with that one. And OHIP, they're the ones who pay the doctor, the insurance group. Unfortunately, we are not in the OHIP fee schedule yet. There is wording in the current agreement that was just negotiated. You probably heard about that in the newspaper that says we're going to figure this out this year. So we're hopeful that by next year this will be done. Okay, now just to cut back to the technology here. So this is what a typical rural site would look like. And I'm sorry the webcast people can't see my pointer, I don't think. But if you look at this cart, this is what you might have in on a rural site, which is kind of a mobile cart. It sort of looks a little medical. It's actually approved for CSA approved for that environment. And you could splash a bit of blood in it and it wouldn't blow up. It's got a little patient exam camera there. It's got a digital stethoscope hanging off the side. There's a VCR for recording educational events, not clinical, but educational events. There's a PC at every platform, and that's a PC screen up there. So if we did have any health records in Ontario, you'd be able to get them up there. Unfortunately, we don't have enough of those. And then we also always give people kind of a big screen they can plug in the back. If they're having a meeting like this, an educational event, then they should be able to get more people into the room to watch that. And most importantly, see, this is our telehealth coordinators. They're all happy. That's the most important part. And this is actually Nancy from Sturgeon Falls, Ontario. This is the Smart Systems for Health Network. Anybody know anything about this? Andy, don't say anything. Anybody know anything about Smart Systems for Health Network? It's probably a well-kept secret. Our government here in Ontario is funding a network that ultimately is supposed to connect 24,000 organizations and 150,000 health providers. I think we were probably the first user when they started to deploy it in 2002. But it's actually mostly Bell's MPLS network. It's what they call a managed private network. We had to design a security architecture to make sure that our stuff would work and was secure. And that's what, I know nothing about this. I'm a doctor, not an engineer. But what I do know is these little tunnels here mean that it's encrypted. So everything that goes across this network is encrypted. That's the key message. These are the architectures that we've designed for different types of hospitals so that they can not only do our application, but they can now manage their other applications, electronic health records, digital imaging, health card validation, whatever else they want to do. They'll be able to manage through this same architecture. And this is the architecture we use outside of Smart Systems for Health. This is what's used for our First Nations communities right here. So we actually use whatever network. We put a VPN hardware box at every site, right beside the video conferencing platform in most cases. It just encrypts, creates an encrypted tunnel over whatever network. So if there's quality of service on the network, we can support video, and this will make sure that it's secure from end to end. But the interesting thing is, this is our First Nation partner. I think this diagram looks a lot like a chief's headdress. You see that? You see that? The services that we offer are a couple. We actually have two formal call centers. So in Toronto, that's where this guy is, there's our technical support desk. It's actually a 24/7 operation that you can call through a 1-800 number that actually actively manages every single component across the province. The second call center is our referral management scheduling call center, and that's most of the staff are located in Timmins, Ontario, with staff connected virtually in Thunder Bay and Toronto, and working with staff in Bombertown as well, the Kiewatinook staff. The video bridging, the bridging is the multi-point tool, so to bring all those sites together, we manage the bridging ourselves. And we have a gateway. Gateway means you have dial-up lines. We have a bank of dial-up lines. So if you want to get out of our IP network, you can go through the IP network all the way down to the dial-up gateway and dial out anywhere in the world that has dial-up video conferencing. So our members regularly go to every other province. They go all over the USA. If you're a cardiologist in Sudbury, you could join advanced cardiology rounds at the Mayo Clinic or whatever you wanted to do through this gateway. We also buy a whole lot of equipment, so we get amazing pricing, which we just pass through to our members. We do a lot of network integration. So there's this Smart Systems pipe. Well, how do you channel that activity through the local hospital network? And that takes a lot of integrating work. And of course, project development. We're very excited. Our members and partners come to us with new ideas for exciting projects, and we like to analyze those and see if we're able to help in some way. This is what you see if you sit at our help desk. This is the sort of tools you'd be using. This tool right up here, I'm kind of addicted to this because it tells me what's going on at this moment. I can see all the activity across the network. Now, if something's not working, they just click on this little IP link, and they actually go right into the remote video conferencing unit. They can't see or hear what's happening in the room, but they can fix the software, reconfigure it. They can even update the software, do whatever they have to do to make sure that event's going to work. They also track every router in Ontario pretty much. If a router goes down at 2 in the morning, somebody from the help desk gets paged and woken up, and often they can get this thing fixed and running before the day's events are missed. That's our referral management center in Timmins. Quite a busy place. So we had to actually build software to support that. We tried to buy it, but it didn't work out because nobody actually had anything that would meet our needs. So we actually built this thing. It's called Telehealth Services Manager that actually keeps track of everything across the network. It's really comprehensive in terms of collecting data. My favorite thing is the canned reports, because I like to know what's going on. I just click on one of these little clicks, and I can slice and dice the data. I can get pictures like this. You know, what's the most active service this quarter? What hospital is doing the most activity? Who are the doctors? All that kind of stuff. So really exciting reporting stuff from our perspective. Where this is going, now that we've so effectively centralized the service, we're quite busy decentralizing the service. So we've built a prototype web portal that our telehealth coordinators will use to manage all of their scheduling needs. This will be done through a scheduling transaction, right? Because we're a collaborative network of member sites. So if member A wants to book something with member B, they don't just go in there and schedule it. They have to ask. So first they see if the time is available, and then they send out a transaction request to do an event. And this is what they'll see. They'll be able to manage their own studios. They'll be able to get to all the forms and things that they want to get to. And essentially, everything they need will be in this portal. I'm going to switch gears a little bit and just tell you some of the special projects we're involved in. We actually deployed a PACS facility at Thunder Bay Regional Hospital that is being shared by the region. So actually 13 hospitals have now gone filmless using that PACS. That's actually an area the size of France, believe it or not. We think it's probably the biggest geographic PACS system in the world. Of course, the people in Alaska tell us they have something bigger, but I don't believe them. But this is quite a large system, and it's been quite effective, quite important to the region. It took us about a year to build it. It took us about 2 years to transfer governance back to the region. So those are the sort of challenges in healthcare. If you're at all involved in healthcare, you'll know that technology is not the biggest challenge. It's really the people. How do you use it? How do you integrate it? How do you make it work in the work setting, as opposed to the technology itself? This is our first emergency service. Has anyone here had a stroke? No? Because if you have a stroke, you should try to get to the emerge department within about 3 hours of your stroke, because they can give you a clot-busting drug on occasion that can actually break down the clot in your brain and reverse the stroke. The only problem is if you give it to the wrong person, you can cause a hemorrhage in their brain and kill them, which is an annoying side effect that we try to avoid. So what's happened over the years is that really only in academic centers or places with expert neurologists is this stuff being given. It's too dangerous to give in community hospitals. So that leaves out really important cities like North Bay and Sudbury were not always able to give this medication or did not have the expert neurologists available to provide advice to the local physicians. So working with those hospitals, we started this emergency program. We put these video conferencing platforms that you see right there into the emergency departments. And then we actually wired up the stroke neurologists, 6 of them in Toronto, in their homes and offices. And this is actually a neurologist living room here. You can see they don't live too badly. It's a fairly spacious living room. It's not a bad profession. And on his screen there you can see the video. You probably can't see it, but there's a little video conferencing, and he can get the CT scan that's taken in the northern community as well. We also built a call schedule, which we've integrated with the Criticall system so that the people organizing critical care services in Ontario, they know who's on call. We developed protocols with the hospitals, and this actually works, believe it or not. This was our press launch, and we brought out one of our first patients. Actually, you know the guy on the left there? Do you know who he is? Wayne's father, right. The great one's father is the spokesperson for the Heart and Stroke Foundation. He had a stroke about 10 years ago. And the fellow on the right was one of our first patients. His name is Tim. He was 42 at the time. He woke up in the middle of the night with half his body completely paralyzed. His wife had the presence of mind to call an ambulance. He got to the emerge. He was actually hooked up to that doctor you saw in the last picture in his living room at 2 in the morning. By the way, if you're in your house and you get woken up at 2 in the morning to do a video conference, you don't actually have to put your pants on, okay? Because you can only see from here up, right? Just so you know. But he saw this patient, and he advised that he be given TPA. This patient is walking. After that event, it actually totally reversed his stroke. And he was walking and talking and went back to work. So that was treatment he simply would not have been able to receive without this technology. This has been quite successful since then. I think we've had about close to 70 cases, and I think 19 have received TPA as a result. And this is now is being adopted by the Coordinated Stroke Strategy of Ontario to really spread out universally to sites across Ontario. We're very hopeful we're going to get funding to support a couple of other sites, Timmins and Sault Ste. Marie, hopefully this year. We're waiting to hear from the Coordinated Stroke people. Our second emergency program is actually Hydro One funded to provide emergency care for electrical burn patients. And all the Hydro employees across the province have the phone number for this in their wallet if they get injured, but it's available to any Ontario citizen. So once we kind of figured out how to do the emergency services, how to build the redundant network infrastructure, how to build a 24/7 help desk, now we can just start to layer these new emergency applications on top of that infrastructure. We also, right now, we're hooked up to 2 prisons. So the idea is that bad guys like this get care in the prison. They don't have to be transported into the community where there's a danger of escape and where they take up a lot of space in the waiting rooms of the emergency department. And, of course, it's really expensive to move these people around because usually you need a truck and 2 guys with machine guns. Usually they're on overtime, so they're getting double time and a half, and they're moving really slow. You probably would too if you're getting double time and a half. And so there's a real business case for the prison system to keep these folks in the prison. But, you know, Ontario, we actually don't get guys like this. This is a famous Alcatraz prisoner. In Ontario, most of the provincial prisons are 2 years less a day, so you get people like Martha Stewart or even this guy. Remember him? Right now, we're actually talking with the prison folks to look at setting up an emergency service as well to try to avoid the ambulance calls to the prison. We're doing, this is, I don't know, an enigma wrapped in a riddle, or because we are webcasting, but now I'm showing you a slide about webcasting within the webcasting slide. It's like the tailor shop where you have that infinite row of mirrors behind you. But what you're seeing in webcasting, I guess the local audience here can't see it, but we're setting this up. We're actually using the EPresent system, same one you're using today. Whenever you have a video conference event, you can webcast that out live simultaneously. You can see the video, see the PowerPoint, chat window for questions. So we're doing this now in a number of cases. We're going to roll this out as a formal service in January. We have a lot of projects under development. I won't go through them all, but just 1 or 2 of these are interesting. One is a nurse practitioner project. There's a lot of nurse practitioners practicing almost by themselves in rural communities, and we're hooking up a bunch of them, linking them back to family doctors to support them, as well as nurse mentors. We're doing that with the Registered Nurses Association and the College of Family Physicians. A lot of new sites all over the place. There's a local project here. We're working with the Canadian Hearing Society. They're going to provide emergency sign language reading. If a deaf patient arrives in the emergency department, needs urgent care, you'll be able to call them and get interpretation whatever time of night or day. And that's actually being deployed at the Grand River Hospital here in Kitchener. People really like this service. Patient satisfactions. I mean, there's not much else in healthcare that gets anywhere close to these numbers. You know, if you surveyed about hospital food, you wouldn't get those numbers. People, you know, there's nothing else like this. Patients love this. I'd love to say it's because North Network's so great, but actually any telehealth program gets numbers like this. It's just a very important service if you live in a rural area. We are currently working on an accountability framework. We're looking at the balanced scorecard approach that's been used in Ontario for hospitals. We've created 5 domains to look at that, and North Network is going to report on 14 outcome indicators.